All right, I think I gave people enough time here, so they'll catch us on whatever slide we are on as I get started here. Good afternoon, everyone. Thank you so much for joining us. This is the Generalized Seizures 101 webinar. It is October 6, 2020, and this webinar is provided by the Epilepsy Foundation of Minnesota. So before we get into the content, I do want to go over some housekeeping items so that we all understand how this webinar is going to go and what we should do if anything is acting a little weird. So this is an hour-long webinar, so that's something that you may want to keep in mind. And then in regards to bandwidth, if you have any video applications or music applications like YouTube or Pandora, you may want to have those shut down in the background. That can affect how this webinar plays. It can affect our audio and our visuals on your end. So I do recommend having those things shut down. I have even been told that having your email on in the background can affect the webinar as well. In a follow-up email, I will be sending a certificate of completion if you do attend the entire webinar, but you do have to attend the entire webinar to get the certificate of completion. Give me a week or so to get that webinar, that post-webinar follow-up email out to you, but after a week, if you still haven't gotten it, please feel free to email me and I'll get that information out to you. My email and phone number is going to be periodically placed throughout this webinar. And this webinar is also being recorded. So if you did want access to this, you can feel free to contact me as well. And then a quick disclaimer before I move on. The information shared in this webinar is to inform you on the aspects of epilepsy. However, all potential treatment outcomes should be discussed with your medical provider. All right, I will also be taking questions. So on your screen, it should look similar to this one. And there's like a Q&A area and there may be a chat. We do have chat disabled right now, so we can't use that. But if you do have a question, feel free to use the Q&A anytime through the webinar. I won't be answering questions until the end, but it's a good way to put in your question whenever you want so that you don't forget your question. We do have somebody who's monitoring that area as the webinar is going. And if you're having any tech issues, unfortunately on our end, we don't have tech capabilities. We all are working remotely. One thing with Zoom I've noticed is sometimes if you log off and then log back in, so shut down the webinar and then try to log back in, if you're having any problems, some people are able to get that sorted out that way. If it's something small that you think you can troubleshoot maybe with us, you can use that Q&A area as well. And we do have somebody monitoring that may be able to help you. But with those tech issues, we do recommend contacting Zoom directly because we don't necessarily know the answers to those tech questions. My name is Jamila Pickett. I'm going to be facilitating our training today. I'm the Senior Coordinator of Education at the Epilepsy Foundation of Minnesota, and my main duties are to provide educational programming throughout Minnesota and Eastern North Dakota. So for those of you who are listening on the phone here, I'm about to read off my email and my phone number, and I'll read that slowly so people can catch it. So my email is jpickett@efmn.org, or you can call me at 651-287-2315. Please give me 3 business days to get back to you, but I do get back faster by email. All right, so the things that you should take away after attending this webinar is that you should be able to define what epilepsy and seizures are, attain an understanding of generalized seizures and types, learn the appropriate seizure responses, and you also should be able to increase the knowledge of available treatment options. All right, so we're going to start off here with a poll. Let me just open that up for you here. All right. So the first poll question we have here is, have you ever attended an Epilepsy Foundation of Minnesota webinar? So your options are yes, no, and then not in a while. And it looks like about 60% of people have voted. So I'm going to give it a little bit more time here just to get everybody in, and hopefully they're all able to get their votes in. We're just waiting on a few more people here. Let me give it a few more seconds. All right, so let me end the poll here. Share those results. So it looks like it's kind of split down the middle. So 55% of us said yes, we have. So welcome back. And then for those of you who are new, welcome. And I hope you do enjoy the webinar today. All right. So to start off today, we're going to review some topics. Maybe if you already know about epilepsy and seizure conditions, these might be topics you already know about. But if you're new to epilepsy, or maybe you're just learning about seizures, these are some topics that you really want to know background on before we get into that content specific to generalized seizures. So epilepsy is a very prevalent condition throughout the globe. 1 in 26 people will develop epilepsy at some point in their lifetime, and about 50 million people across the globe have epilepsy. 1.2% of the US population has epilepsy, and so that's about 470,000 children and nearly 1 million people over the age of 55. 1 in 10 people will have a seizure at some point in their life, and you don't have to have epilepsy or a seizure condition to fall into that statistic. So everybody who is listening to this webinar right now has a seizure threshold. Any living organism that has a brain has a seizure threshold. And we all can be pushed past it. There are specific criteria that qualifies a seizure condition or epilepsy, which I'll talk about in a second here. So just remember that any of us can have a seizure. Another statistic that I like to talk about is school settings and class sizes. So even though you may not be in a school specifically, it's nice to kind of think about a class size, so about 30 or 31 students. So when you're thinking about that, about 1 child in every other classroom has epilepsy. Now, of course, there's going to be a give and take there, but when we're thinking about that statistic, many people might not be disclosing that they have epilepsy, or maybe they don't have epilepsy themselves, or they have epilepsy themselves, but they haven't been diagnosed themselves. So that is definitely a statistic that is quite prevalent, but we might not notice it or just know of those people who have epilepsy. So what is epilepsy? It's a neurological condition that causes reoccurring seizures. So on your screen here, you see this brain kind of lighting up with different electrical activity, and that's really to show what's happening in our brain constantly. We always have electricity moving and kind of working together to tell us what to do. For it to be epilepsy, it also has to do with the electricity in a person's brain. So it has to happen more than once, it has to come from a person's brain, and it also has to do with the electricity in that person's brain. Some people may call their epilepsy seizure disorder or seizure condition. I would take that with a grain of salt because the term seizure disorder or seizure condition is more of an umbrella term that a lot of other conditions can fall under, such as epilepsy. So it's not wrong to call your epilepsy a seizure condition or seizure disorder. Just remember, though, that just because somebody calls it that does not mean that they specifically have epilepsy. It might be another seizure condition. So these are all things that qualify a seizure or seizure condition into being epilepsy, but again, remember, any person can have a seizure at any time, and it doesn't necessarily have to be associated with a condition. So when we're talking about epilepsy, of course, we want to talk about what seizures are. Seizures are the symptom of epilepsy. different parts of this brain are kind of lighting up, and that's to signify that they are in charge of different functions in our body. Throughout these different parts, we have pathways, and on these pathways, we have electrons, and the electrons are actually the electrical signals that I talked about before. What happens when our brain is functioning normally is the electrons and the pathways and these different parts work together to allow us to do what we do every day, such as breathing or sitting, watching TV, etc. When somebody is having a seizure associated with epilepsy, what can happen is these neurons get sent when they're not supposed to. That's called a misfiring, and that's what can change a person's awareness, sensation, movement, and that's the seizure being visualized in that person. Depending on what part of the brain that misfiring starts from, that's what the seizure is going to look like. So let's say that misfiring is affecting the occipital lobe. This is the part of the brain that deals with things like eyesight. Then this person's seizures might be seeing things that are not actually there. On the other hand, perhaps this person's entire brain is being affected by misfiring activity. Then this person may have entire body convulsions. So it really does depend on what part of the brain is being affected. Unfortunately, 60% of epilepsy cases have an unknown cause, but of the known causes, head trauma or brain injury is the #1 known cause. When we're thinking about causes of epilepsy, a good rule of thumb is anything that can cause head injury or brain injury can cause epilepsy. And as you can see with a lot of these examples, that is true. This is a limited list of causes, and it would be impossible to put on the list every single thing that can cause epilepsy, but this gives us a good idea of different things that can result in somebody developing epilepsy for sure. All right, so we just went through some of that review. Now we're going to move into that content specific around generalized seizures. If you attended my Focal Seizures 101 webinar, some of these slides may be a review again for you, but we are definitely going to be talking about a few generalized seizures specifically, how we're going to respond to them, and really what seizure type and classification are. So when we're thinking about generalized seizures, we have to understand what seizure type and classification are. And that's because a generalized seizure or generalized seizures are a type of classification. So a person who has a seizure type, it really describes what their seizure looks like. And then that classification piece that works in with the name of the type will tell you where in the brain that misfiring is starting. So there's not an exact number of seizure types. If you've heard any of my webinars in the past, many times I usually say 40 plus. And that plus language is kind of like a disclaimer a little bit, because that number is changing all of the time. The 40 number might be a little bit high at one point or maybe a little bit low. To be honest, it's hard to put a number on it because there are seizure types that we right now don't even know about. Also, sometimes we break down categories realizing that there are seizure types that are really different, but they're classified together, or sometimes we put together types that used to be separated. So if somebody asks you how many seizure types there are, you can definitely say that 40 plus number for sure, but it's also important to remember that we don't really know exactly how many seizure types there are. Seizure type is partially determined by classification, and classification is talking about how they begin in the brain and where that misfiring begins in the brain. Classification is a dynamic process that helps us understand and allows us to group seizures by type as science evolves. So for a person who is not educated on seizures and epilepsy, when you say that I have seizures, the first thing that might pop into their head, as it does for a lot of people, is, oh, well, you have convulsive seizures. But as many of us know, there are a lot of different seizure types, and a lot of them are not convulsive. They can look really, really different. And so when we're communicating with people, we want to be able to express exactly what the seizure looks like and where in the brain those seizures are starting, both for diagnosis, treatment, and when we're going into school settings or work settings and different places like that. I like to use this image, this chart, to talk about classification and explain it a little bit more, because it really simplifies and lays out the different classifications at real base level. So we have the focal onset, generalized onset, and then the unknown onset. An important word to pay attention to on this slide is onset. So that means where in the brain does that misfiring start? Now, when we're thinking about onset, remember that just because a seizure can have a specific onset doesn't mean that the seizure can't change. And I'll talk a little bit about that in a second here. So focal onset seizures used to be known as partial seizures, and we moved away from that terminology because it just wasn't descriptive of what happens in a person's brain when they're having this type of seizure. Partial refers to one hemisphere or one side of the brain, and that's not actually what happens when somebody is having this type of seizure. A specific part of the brain, or a focused area of the brain, is being affected by misfiring activity. So when I think of the word focal, I like to think of the word focused, and that helps me remember that it's just one part of the brain, one specific area. Depending on what area is being affected by that misfiring, this person's, during their seizure, may have awareness or they may have impaired awareness. Then we have the generalized onset seizures. These are the ones that we're going to be talking about in depth today. Generalized onset seizures affect the entire brain, so this person is always going to have some sort of impaired awareness. Lastly, we have the unknown onset, and the name itself describes what it means. So we don't really know where in the brain that the seizure is starting. Eventually, hopefully, this person will find out, because that can help with what medications they're taking and what other treatments they can have. But that's why this person may be in this category. When we talk about diagnosis, you'll understand more why that unknown onset area is really needed. So something that I mentioned before is maybe a seizure can start with one onset and then change. What I mean by that is maybe somebody has a focal onset seizure. Just because its onset was focal does not mean that that seizure cannot generalize throughout the entire brain. So it can change from its onset. From there, we have different motor and non-motor behaviors that are going to be associated with these classifications. So this chart here kind of expands on what I previously talked about in that first slide. It actually is the same slide as the previous one, except this one just has a lot more detail. So as you can see, it has the focal onset, generalized onset, and then the unknown onset as well. So we know that the focal onset may have awareness or impaired awareness, and then with that generalized onset, we see that it doesn't have those classifications there, because we know that this person is always going to have some sort of impaired awareness. From there, after we establish their awareness, we have some terms here that are associated with motor characteristic or non-motor characteristics. I want to focus on the generalized onset area right now, since that's what we're focusing on today. But you can definitely take a look at the other two with the unknown and the focal onset and see some similarities in how we're naming these seizures. So first, we have the classification. So this person is having generalized seizures. Then we want to understand what these seizures look like. What is the characteristics of this seizure? From there, we would say if this person is having a generic convulsive seizure, the one that people think about when they think about epilepsy and when they think about seizures, then they would maybe have a generalized tonic-clonic seizure. And with that language, I know that it's generalized. So that means this seizure is affecting their entire brain. And from my background knowledge of this terminology, I know a tonic-clonic seizure means stiffening and then convulsing. So this person is having a seizure that's affecting their entire brain, and that is making their body stiffen and then convulse. And those other terms underneath are also other words that can describe what the seizure looks like. So sometimes when we see that medical terminology, it just kind of looks like a whole bunch of things that we don't really understand. But when we really break it down, it's describing what the seizure looks like and really what it means. We will be going over some of these terms later on, but really just trying to put forward that these terms and these types mean something. Two other areas that are touched on this image that was not in the previous slide is that unclassified area and then the focal to bilateral tonic-clonic. So unclassified is different from unknown in the way that we understand what's going on. Maybe we know where the seizures are starting perhaps, or what they look like, or maybe the way that it's behaving in their brain, but there's not a specific seizure type that's um, already named that can be associated with this person. Maybe they don't know another person or don't have enough cases that are specific to this type of seizure for them to have a name yet. So that's really why that can happen, and somebody can be in that unclassified area. Again, it's pretty descriptive in its name itself. So it also goes in and says due to inadequate information or inability to place it in other categories, and that's very true there. And then we have the focal to bilateral tonic-clonic. That's underneath the focal onset seizure. We'll go into a little bit more depth later on about that one. But again, as I said before, a seizure can start with a focal onset and then move into a larger seizure or generalized. And that is what that focal to bilateral tonic-clonic is. So the benefits and really the need to classify really comes down to these few areas here. It aids in communication. So as I said before, you start a new job and you say, I have seizures, and they're going to make reasonable accommodations for you. And they're thinking, oh, well, let's make sure that we have maybe something soft around so that when you have your seizure, we can turn you on your side, and we'll make sure that we have posters on what to do when somebody is having a convulsive or a tonic-clonic seizure. And then they come to find out, wait a second, this person's seizures are not convulsive. They're maybe staring off for a couple of seconds. And so preparing for that seizure, they probably maybe should have had some memory tools or maybe some reminders or things like that, but they prepared for a completely different seizure type. And so that helps with communication because not every seizure type is the same. It also allows for the establishment of a diagnosis. So again, if somebody is having convulsive seizures, they may have a different treatment option than somebody who is having seizures that make them stare off. Or for some people, maybe they're having focal seizures and they need a different treatment than somebody having generalized seizures. And so that is definitely helpful there. It also helps define the seizures. So what they look like, what is happening in the brain, and where the seizures start and end in the brain. All right, so I went through a lot of charts so far, but some of us think better when we're looking at an image of what's actually happening. So I added this picture of two different brains. One of them is a generalized seizure, one of them is a focal seizure, so we can really understand what's happening in a person's brain when I'm saying generalized or focal. When somebody is having a generalized seizure, that onset will affect the entire brain. So as you can see in that first brain, the entire brain is red because the entire brain is being affected by the misfiring that has happened in that central focus. On the other hand, in this focal seizure, we can see that only a limited area of the brain is being affected. This area where we see that circle and just a few arrows affecting this red area that's just in the corner of the brain, that's a focal seizure. A specific area is being affected. So that's really the difference that we're looking for when we're saying generalized or focal seizure. Generalized seizures affect the entire brain. Focal seizures affect just a specific area. Some common symptoms of generalized seizures can either be motor or non-motor. So if they're motor, so physical, it can be jerking movements, maybe convulsive movements, muscle weakness or twitching, spasms. This person can have their body become tense and rigid, so maybe a stiffening, and then twitching as well. Some non-motor symptoms often associated with the term absence can be things like staring, maybe while they're staring, they can have brief twitching of their body parts or other, maybe their limbs or eyelids as well. So I talked about terminology a little bit already. These are just some key terms that I pulled that I use quite a bit. But again, this is just a small list of terms. You can definitely learn them all. I know that in the work that I do, I slowly learn what a lot of these terms mean, and that can help you understand when a person is specifically saying, hey, I'm having a focal aware seizure, or I'm having a absence seizure. You kind of know what those terms mean and what their seizures may look like. So the term clonic means jerking, or that's often associated with convulsive. Atonic can be limp or weak for some people. If they have atonic seizures, their entire body just kind of falls at one time abruptly. Tonic means rigid or stiffening. So the tonic-clonic seizure is the convulsive seizure people typically talk about. And so we know that that is a rigid seizure, then that turns into a more jerking motion. And then we have the myoclonic or myoclonus, and this is a twitching motion, a lot of times with your limbs, so isolated limb movements. All right, so I'm gonna put up another poll here for us all to go through. All right, so how much of the brain is being affected by a generalized seizure? So the entire brain, a specific area of the brain, or it depends. So I'm gonna give people some time here. Looks like these votes are coming in. I'm seeing a lot of right answers, so that's good. I'm going to give you all more time here. It looks like about 60% of you have answered the poll question. Thank you so much. And for those of you who have your thinking caps on and kind of thinking here, I'll give you all a few more seconds to get your answers in. All right, let me give it about 5 more seconds. And let's see if we can get that last 30% here to put in their answers. All right, let me end the poll. No one got the wrong answer, so I'm glad to see that. So I did notice in this poll question, I didn't say generalized onset seizure. So I can see why somebody says it depends, because perhaps the seizure generalized, but it started focally. So maybe that's that 33% that got it put in, it depends. Maybe that's what you were thinking. For those of you who said the entire brain, definitely. If it's a generalized onset seizure, it is going to affect the entire brain. So I'm happy to see that I didn't get any wrong answers here. All right, let's move on here. All right, so now let's talk about the diagnosis process. Before I get into these bullet points, I do want to stress that this is the typical process and not necessarily what every person will go through when they're being diagnosed. And I also don't want to set up false expectations here because, yes, a person can definitely go in and be diagnosed very quickly. That's something that can happen. But for some people, it does take quite a while to properly be diagnosed. So there are these clearly defined bullet points, but that doesn't necessarily mean that you might not be stuck or stay at one of these bullet points for a while before you move to the next one. So again, not to say that a person couldn't be diagnosed quickly, but at the same time, it can take a while for some individuals. So typically this person is going to see a physician. Usually it's their primary care, but depending on what their medical background is in the first place, they may already have a neurologist or will see a neurologist first. From there, a complete medical history and physical examination will help rule out any other possibilities. Maybe it's another condition. It's really to understand what is the likelihood of these symptoms actually being epilepsy. And then that next bullet point, so possible tests can include blood tests, so biological tests, or maybe some imaging such as EEGs, MRIs, or that CT scan. This is the bullet point that a lot of people spend quite a bit of time on. And it's because specifically with that EEG test, it's looking for misfiring in a person's brain. Where in the brain is that onset? And that usually only happens when somebody just had a seizure, or maybe are about to have one, or are having a seizure. So of course, you're going to make an appointment for the EEG, right? We can't plan out when a seizure is going to happen. And so what happens if you go in for that EEG test and you're not having any misfiring in your brain? Then they can't diagnose it, what onset that is at that time. Now, there's a lot of other reasons why you can be held up during this process, but that's many times where a lot of people have to continuously go in to try to get that testing to see where that misfiring is starting from in their brain. Now, for some people, we know of triggers, and maybe the doctor might recommend, depriving them of sleep or something like that to try to stop or start a seizure so that they can do that EEG test. But for others, maybe they don't have a trigger and they don't know when that's going to happen. So that's important to keep in mind. Once completed, an assessment of further treatment or referral to a specialized physician will take place. Perhaps you would be referred to an epileptologist or a neurologist. It's really deciding where do we go from here? How do we treat what we have just diagnosed or found out? All right, so the first generalized seizure we're going to go into depth about is the absence seizure. Absence used to be known as petit mal. Petit mal in French literally translates into little bad. So there are obvious reasons why you wouldn't want the word bad in the name of your medical condition. So it's adding that human decency there, that humanity into that name, and actually it's just much more descriptive. Absence, there's an absence visually that you can kind of see in this person. So it's brief and sudden lapse of awareness. It can be characterized by brief staring or rapid facial movements. And this person typically will quickly return to their awareness. Now, this is talking about a typical absence seizure. I will go over the two different kinds here, but just keep that in mind. The protocols and the characteristics that I'm talking about are referring to typical absence seizures. They typically last 5 to 20 seconds. I will say 5 to 10 is a number I like to keep in my mind when I think of typical absence seizures. And this one can be confused with a lot of other conditions. So the next clip here is actually a child having this type of seizure. I'll play it once just so we can all see what it looks like, and then I'll play it again just so we can look at it and see if we missed anything.
This girl has absence seizures, and you will see her have one while she's talking.
Because he can be as heavy as ever.
And there's a real blankness, a vacant look in the eye, and then all of a sudden they're right back with you and able to engage.
All right, so as we saw, she was talking, and all of a sudden it seems like she kind of trails off for a second, and then she comes back and says, "Pardon." She's trying to figure out where she was in the conversation. So with typical absence seizures, there's not a recovery period. So this person should just go back to whatever they're doing pretty naturally. Sometimes you have to remind them of what they were doing, but there is not a recovery period, and that's actually a sign of an emergency. Outside of that, there's usually not a response. But again, if it's an atypical absence seizure, you may need to refer to their seizure action plan, which is true of any of these seizures. So I'm going to play it one more time here for us.
This girl has absence seizures, and you will see her have one while she's talking.
Because he can be as heavy as ever.
And there's a real blankness, a vacant look in the eye, and then all of a sudden they're right back with you and able to engage.
All right. So characteristics of an absence seizure. So a person may have typical absence seizures or atypical absence seizures. A typical absence seizure is what I talked about before, that 5 to 10 seconds, they don't have a recovery period, and they kind of go back to whatever they're normally doing. If somebody has atypical absence seizures, though, that time will be much longer. So it could be maybe 20 seconds to 30 seconds. Perhaps this person maybe is having the seizure for minutes. So that is one key factor with absence seizures. A lot of times it's harder to treat absence seizure or atypical absence seizures. And another key difference as well is a lot of times people may have some isolated limb movements with that atypical absence seizure. So definitely there are other differences, but those are those main ones that you can look out for. Please refer to this person's seizure action plan on how to specifically respond to their absence seizures if needed. This person is not aware this is a generalized seizure, so that means that their entire brain is being affected. So if you say something to them during their seizure, you will have to repeat it afterwards. They may stop talking or pause whatever they're doing. For some people, they, after the seizure is over, will go back to whatever they're doing automatically. For some people, they may just need a reminder or kind of letting them know what's happening around them. Some may have a lot of absence seizures in a day. There are people who are newly diagnosed that could have hundreds of these seizures in a day because they are very short. And the typical person goes back to whatever they were originally doing. But again, this is going to be for a typical absence. That atypical absence does have specific characteristics. Now we're going to move into the generalized tonic-clonic seizure. So I've talked about this a few times already. This used to be known as the grand mal. So again, we're moving away from that old terminology and trying to move towards more descriptive terminology. There's typically a progression. So first you might hear maybe a sudden cry or maybe moan. And this is because not only are we convulsing externally, but we're also convulsing internally. And so that air is getting pushed out when this person is having this seizure. They do lose complete consciousness and they may fall, and then their body may extend and get stiff. That's the tonic phase. And then you might notice some rhythmic shaking or jerking afterwards. That's the clonic phase. Additional effects may be present as well. This person may have, they may vomit, they may lose bowel or bladder controls during their seizure, and it is common for a person to bite their tongue or their cheek as well. This one typically lasts 1 to 3 minutes. This person may feel sore, tired, or even confused afterwards, and they may have a headache. A lot of people do need to take a bit of a rest after the seizure is over. So the next clip here is a child having a tonic-clonic seizure.
They affect the whole brain and the entire body. The tonic phase is the stiffening of the muscles. Then the jerking movements begin, the clonic activity that you see here. A tonic-clonic seizure rarely lasts more than a few minutes. A person having one isn't conscious and won't remember what happened. The skin may become pale. Breathing may seem shallow or labored. Sometimes a child may lose bladder or bowel control or vomit as the seizure ends. These seizures may look painful or even life-threatening.
All right, so as that clip ended, we heard the narrator say, these seizures may look life-threatening, they might look painful, but I do want to note, in reality, most seizures are not emergencies. That is not to say that you should not always treat each seizure as an important response, that you want to make sure that you are treating this person with respect and care when you're responding to this seizure every single time. And that you're keeping this person safe. But again, it can look distressing to someone who's never seen a seizure before. Follow those guidelines that you see in their seizure action plan, and then also follow the response that I will be talking about in the next slide here as well. So when somebody is having a generalized tonic-clonic seizure, the first thing you want to do is time the seizure from the beginning until the end. So as I said before, 1 to 3 minutes is typical of this seizure. 5 minutes is when you want to call 911 unless their seizure action plan says otherwise. Some seizure action plans, in fact, I'm seeing a lot of seizure action plans now saying 2 or 3 minutes. So follow that number. The second thing is you want to turn them on their side. I'm in the Midwest here, so we always have jackets lying around and other soft things lying around. So after you turn them on their side, you want to put something soft under their head. And that's because sometimes people hit their head pretty hard on the ground when they're having the seizure. And we want to protect their head because that's where the seizure is coming from. Now, let's say you're somewhere and there's no pillows or something soft around that you want to cushion their head with. Another thing you can do is put their head on your lap, or you can cup your hands underneath their head and let their head freely bounce off the palms of your hand. And this is another way to protect their head and not be so invasive. The reason why we want to turn them on their side is because if there's any saliva or secretions, or maybe they vomited, those secretions can freely flow out of their mouth and they'll have a cleared airway so that they can breathe. Now, we used to be taught to put wallets and spoons and all kinds of things in people's mouths. Never put anything in a person's mouth during a seizure. Turning them on their side will allow them to breathe. And actually, we have now found that putting things in their mouth, though medical professionals used to do this, actually can harm a person. Remove anything that might get in the way of you responding to the seizure, such as furniture, or for example, this example uses glasses, anything that gets in the way. And then you just want to stay with this person until they are fully aware. Again, they may have a headache after the seizure is over. They may have other symptoms or other things that are, making them tired or things like that. So you may want to just let them rest and help them if needed. All right. So characteristics of generalized tonic-clonic seizures, so we have GTC abbreviated up there, is the person is having a seizure and they don't know what's happening during the seizure because it is generalized. The response needs to be focusing on their breathing and keeping them safe. And so that's why we turn them on their side. And we really want to make sure that that airway is clear. Don't have anything in front of their face. I will say the most optimal side is to turn somebody on their left side, but turn them on whatever side you can safely put them on. After the seizure is over, the person may be very tired or need to take a rest. All right, and so I have this slide after the generalized tonic-clonic seizures, and this is because this is that focal to bilateral tonic-clonic that we saw before. So as I talked about, we are moving away from old terminology. So we no longer say focal to bilateral tonic-clonic, or at least we don't try to. And we try to use that secondary generalized seizure language. This is the one where a seizure may start focally. So it starts in a focused area. That onset is focal, but then it generalizes throughout the entire brain. And so the entire brain is affected by that misfiring at that point. This one starts in one area and spreads to the entire brain. It usually lasts 1 to 3 minutes, and this one may have a long recovery period. If it lasts longer than 5 minutes, you do want to call 911, but you also want to make yourself aware of their seizure action plan. This may be abrupt and can progress quickly, and consciousness usually returns pretty slowly. This one is diagnosed with that EEG, so that's that electroencephalogram that I talked about before. So we're seeing that it starts focally and then generalizes, and we are able to understand that through that testing. And again, it used to be known as the focal to bilateral tonic-clonic seizure. All right, so when do we call 911? If it is a first-time seizure, or if it's the first time of you knowing of this person having a seizure, if an injury takes place beyond what you can attend to, I always say a scraped elbow is not one of those injuries. If someone stops breathing at any time, so especially during a tonic-clonic seizure, it is normal for somebody's skin color to change, maybe lip or nail bed color to also change, and their breathing may be erratic. That is normal. After the seizure is over, if it may take a minute or two for it to get back to normal. So don't freak out if it doesn't go back to normal right away. If you're noticing though it's taking a while or any other abnormalities outside of that seizure action plan, you do want to call 911. What is never normal, though, is for a person to stop breathing before, during, or after the seizure has taken place. Now, I have heard a lot of different opinions around this, but we always say if a person stops breathing at any point, call 911. If the seizure enters status epilepticus, so that newer medical terminology says that's a seizure that lasts more than 5 minutes or clusters one after another without hitting the recovery period or baseline. If a seizure takes place in water, uh, a person can go their entire day with water in our lungs and we can feel fine. Going to sleep with water in our lungs is a risk of drowning. So you do want to make sure that you call 911 if somebody has a seizure in water, even if they seem like they're fine. We want to make sure that airway is clear. If they have another health condition such as diabetes or pregnancy, or if you just feel like you can't respond appropriately, find somebody who can or call 911. All right, so these are some of the treatment options that individuals can or may have access to once they figure out, what kind of seizures that they're having, what the classifications are, what their seizure characteristics are. Most people do go on some sort of medication therapy. That's a very popular one, and about 70 to 75% of people do well on that option. But some people don't, and they may have to look at other options or maybe combine options with each other. There's also some brain surgery options. There are a lot of brain surgery options. And if you want to learn more about some of these treatment options in depth, you can definitely uh, tune into one of our other webinars that go into these details. But when we're thinking about brain surgery for generalized seizures, it's not going to be a brain surgery typically where you're removing the part of the brain, right, that the misfiring is happening. Because this is a procedure that can be done if you're having focal seizures. But if your entire brain, the onset is the entire brain, you're having generalized seizures, obviously we can't remove the entire brain. So there are specific procedures for focal and generalized seizures that may be appropriate. Some people have devices implanted, so they may have one underneath their chest that connects with their brain. Maybe it connects with the vagal nerve that sends electricity to their brain. And some people have the device right on their brain. And they all kind of have the same basic function of sending electrical activity throughout the day to the brain to kind of help regulate any seizure activity. And there's ways to try to stop the seizure as well with these devices. Diet is another way that people use therapy and medication a lot of times together to try to help regulate seizures. The ketogenic diet is a popular one. It was made over 100 years ago for epilepsy specifically, but you may also notice the modified Atkins diet as well and some other ones. And then medical cannabis, depending on where you're listening from, may be an option as well. I know our friends in North Dakota have medical marijuana. That's just what it says in their legislation. And here in Minnesota, we have medical cannabis. So you want to make sure that you are looking at your own state's rules and regulations around that, or even if that's a treatment option at all. All right, so we are getting to the end of the presentation here. I have already gotten a few questions, which is great. So please feel free to start entering any more questions that you may have here as I'm going through these last few slides, and then I will go over them. Something I want to highlight is we do have information services. So these are free one-on-one supports. They can be customized, and we have tools and resources that can be used around that. We can go over a variety of epilepsy-related topics, and you can request materials. If you want to learn more about our information services or would like to utilize those services, please contact Debbie Leone. She's our Senior Coordinator of Information Services. For those of you who are listening on the phone here, I'm going to read off her email and phone number. Her email is dleone@efmn.org, or you can call at 651-287-2303. EFMN's mission is we lead the fight to overcome challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. We do have our general contact information. You can go to www.efmn.org to learn more. And we do provide many of our education services absolutely free, and we're able to do that through donations from wonderful people like many of you listening today. So please feel free to make a donation if you would like, and you can find that link. I'll be sending that in the follow-up email, or you can find that on efmn.org. All right, so I'm going to quickly just go through these reference pages here just for the recording. And then I'm gonna take questions. So let me just open up this questions area, and please feel free to continue to add questions. We have about 6 minutes here. All right, awesome. All right, I have one question here that says, can we revisit? Okay, involves versus how Word. Okay, so the question is, can we revisit tonic-clonic description? Tonic-clonic seizures involve both tonic stiffening and clonic twitching or jerking phases of muscle activity, is how we've described it before versus the use of convulsion in another complicated word. Yeah, so when we're thinking about tonic-clonic seizures, let's really think about those descriptor words, though, that medical terminology that we're using. So tonic is stiffening, and then clonic is going to be that jerking or twitching motion that you see individuals have, and it is very descriptive in its name. Let's see. All right, and then I have another question here. It says, with absence seizures, you mentioned that there is a recovery period. This could be a medical emergency. Please expound. I'm a nurse. So yes, with absence seizures, let me break it down for a second. So typical absence seizures. Now, atypical absence seizures may have a recovery period. It may be more complicated. So there are definitely going to be more variables that we have to think about with a atypical absence seizure. But with a typical absence seizure, the one that lasts between 1 to 10 seconds, or maybe even 1 to 20, depending on the person, with these seizures, after the seizure is over, this person shouldn't struggle to get back to their baseline. At most, they may, oh, what was I just talking about? Or they may ask what they were doing or where they were at, but they shouldn't have a physical response to the seizure that just happened with typical absence seizures. Now, again, every person is different, so their seizure action plan may say, well, this person does have a recovery period. It can depend person to person, but generally, if you don't see that documentation anywhere, after the seizure is over, they should go back to what they were doing normally and not need to have time to like sit or recover. And so that's what that really means with typical absence seizures. All right. All right, and I got some feedback as well in the question and answers. So thank you for a lot of that feedback around a lot of the materials that we offer. And for the person who asked, can this presentation be emailed to attendees? Yes. So please look out for that follow-up email. In that email, I will include the presentation PowerPoint as a PDF. All right, would the recovery period post-absence seizure, the medical emergency, just mean refer to a clinic, not an ambulance call? So again, I would refer to their seizure action plan. The way that I learned it with the absence seizure is if it seems like they are struggling to get back to their normal awareness outside of the absence seizure, I have always learned that might be a call to 911 actually, and not just a reference to a clinic, particularly in a school setting especially. But again, it is going to depend on the person. But yes, that is referring to a medical emergency. For recent head. Okay. Would it also mean in the school setting assessing for recent head injuries or other signs of illness like fever going on? Okay. So in a school setting, I'm thinking I'm understanding what this means. And we also will have these questions here logged. So if I don't get to your answer today, we will get that answer to you in a follow-up email. But from what I'm understanding is when you're assessing for a recent, when you're in a school setting, you can assess for things, other variables like a recent head injury or signs of illness. If a person has a documented case of specific seizures, it should say in their seizure action plan uh, how you how you would respond to that specific seizure. But definitely, when we're thinking about a person, especially with a head injury, they probably a 911 call probably needs to be made, and even other illnesses as well, because if they don't have a documented case of epilepsy and then they have a seizure due to a cold, that is still a 911 call. Even if they do have a documented case, though, and it's outside of the norms of their seizures, that definitely is a 911 call. And please feel free to email me if you have any further questions or need clarification. But it is 1:01 right now. Wow. Thank you so much for all of these wonderful questions. My name is Jamila Pickett. You can email me with other questions or other clarifying questions or comments at jpickett@efmn.org. Or you can call me at 651-287-2315. Thank you so much for everyone who attended today, and I hope you learned something. Have a wonderful day.